This is the Digital Health Agency. We are 1 year old, and we thought what better theme than to look back and look at the pains, the gains, and the opportunities. The video that you just watched summarizes our mandate and summarizes what we have been able to do, but also gives you a snippet of how the future looks like, given that our mandate is to really lead and steer the digital health transformation agenda in this country. With the leadership, under the leadership of our CEO, Engineer Lenayara, a very passionate human being, a very passionate technical team, an overall DHA team, and together with stakeholders, we look forward to seeing a time when there will be only one digital health record for every Kenyan.
Whenever you want to do any transformation or any radical change, nothing moves without leadership. And that leadership starts from political leadership. I want to take an example of the social health insurance. When we started talking about social health insuring and transforming the country many years ago, when we had the former president, Kibaki, and it was so-called Gilu Bill. That bill went and was passed in parliament and died there. It took us another 10 years. So before the politics decides that this is the way to go, and that one of the things that I think that the health sector succeeded in is making sure that this was an agenda of all the parties which were coming in. So the first is the top leadership in political, and you have seen how you can pass bills and make them work within a short time if all the political leadership is in it. Now, coming back to Kisumu, where I come from, my governor, Professor Peter Anyang' Nyong'o, has been a strong believer in social democracy. And we can see when he became governor, this is the first thing that he put in the manifesto, that one, we must be able to take care of the indigents and everybody must get equal health care. Two, we must be able to digitize our systems. Now, he started all the way from the community health all the way upwards. And when we started doing this, it looked like a very expensive thing, and I'll take very short time, that we asked the county assembly to pass a 130 million, which is almost 30% of the recurrent budget, to digitize community health systems. Now, that would never have passed through without political leadership.
We discovered that stability comes first. We think that no matter what kind of good rules or workflows you have, when the system is unstable, then the rules and workflows don't matter. So for instance, and we have been very vocal about things like OTP delays. We have been vocal about things like how they disrupt service delivery. Now, the other one is, another lesson we have picked up is predictability is as important as stability. So what do I mean? I mean that, for example, when we have a change in the rules, for example, eligibility, pre-authorization workflows, that kind of, to use a term, policy ambush. We need to make sure that we don't have policy ambush and we have a system that is predictable.
The digital superhighway became an important component as an enabler of good service provision, quality access, the issue of people being able to pay for it, and also, availability of the same within the villages. And I think there are critical components that we cannot forget within this digital superhighway. One, the ability of people to identify themselves uniquely and to seek care within the facilities which are closer to them. The second thing was the issue of telemedicine, which became an extremely critical component in enabling even those in the remote areas to access quality care, even if the human resource challenge still persists, because it takes time to build up a human resource that, of course, will be available within all the physical locations of our facilities.
I want to appreciate the fact that the key component is ownership of the process, starting from the top leadership of our governor, His Excellency Stephen Sang, because he's the one who launched the digitization of services, and that makes it easy down the chain. And also we sensitize our staff on the importance of this, because without their ownership, they are the champions, they are the implementers of the system. Now, what is we've learned in the process is that we've attained about 60% digitization of the primary healthcare facilities with a dashboard that we are able to see what they are doing every day, the number of patients seen, the number of patients booked for the clinics. We are able to see the number of SHA claims that they are doing. We are also able to note the workload. We are able to see the facilities that have higher workload against the number of staff that they have. And this gives us an opportunity to redistribute the staff where we find the workload is low and yet the numbers are relatively higher than other facilities.
Tell us the situation in Kisumu. Building up on what Dr. Angeline has told us, what they have done, 60% of the facilities being digitized. How is it in Kisumu now?
Thank you very much. I think Kisumu is younger yet older. Kisumu started digitization much earlier, and I think almost 40% of our facilities were digitized. But then all those facilities were silo facilities. That means that if you moved from facility A to facility B, you are a new person. You have to start afresh. They register you and get all your data. And so, yes, we were digitized. We had a lot of innovations, but then we did not have that interoperability layer being brought forward, even though we were even using the same system. We were mainly using Kenya EMR system in most of our facilities. We have now activated the Taifa Care system, and we will be now moving into the digital superhighway. The Kenya EMR system is being upgraded into a newer version that can be able to link. We will then be able to discuss on how we can save this data, because once you start generating data, initially, most of our data was in several places because of the partners, and you know the USAID and the US government is transitioning into a locally run system. And so the DHA will have to provide at one point a repository where all this data will be coming into.
As a regulator, what is your experience in regulating facilities and regulating healthcare workers? And how can DHA help you sort out all the challenges that you experience, as you give us your parting short remarks?
As regulators, we implement government policy through legal frameworks. And so ours is largely to keep minimum, the standards and norms that are expected to be able to provide quality care for the needs of the population. And we do continuously support facilities to be able to maintain the standards or even take them higher than what they have been having. In terms of the health professionals themselves, we also maintain the standards right from the training, then ensure that everyone is registered and licensed to practice within the scope of the training that they had achieved.
Today, as we gather, we want to evaluate how far we are on this. What are the gains? What are the opportunities? And where were the pains? Just to give you a high level, in 12 months, we have made significant progress as the Digital Health Agency led by our CS and our ministry in digitization transformation agenda. As we sit here today, we are rolling out Taifa Care Hospital Management Information System that makes each and every public hospital to go paperless. We are in 24 counties and counting, and we expect to complete in all counties by November 2025. Our health information exchange is also live and working, making identification of systems across the 25 million Kenyans who are in the USC program possible. Every patient today is uniquely identified through the client registry integrated to our registration bureaus, eliminating the need for physical health records and physical health cards, and preventing fraud under the Social Health Authority. All healthcare facilities and professionals are now uniquely, seamlessly identified through our regulators, eliminating fake doctors and fake facilities and provision of services by unqualified health professionals to the Kenyan people.
Once upon a time in Kenya, there was very little visibility of when a patient would walk into a hospital, the services that they would get, the lab work that would be done, the treatment protocols that were issued, and then the discharge of the patient, and even the follow-up of the patient. But with our collaboration with the Digital Health Agency, we now have back-to-back full-end visibility of a patient and a patient's journey. And if we look at what is coming up next, what is left undone, which we are working on, is that every Kenyan will be able to have access to their record of services. It means you as a Kenyan will be able to know in January you went to the hospital, 2 years later in February you had your CT scan, 3 years later you went in for this surgery, and that really is monumental for us. One, as we adjudicate claims, but two, for you as a patient, as we make sure that you get quality health services. And then for us in SHA, our partnership in DHA continues. And really, if you look at the work that has been done from the inception of this program to date, we're extremely pleased and there's more to come.
For WHO, we provide 5 design tests for equity, justice, and inclusion. For us and for the global health community, before any solution scales, WHO proposes that counties and vendors must pass this test. 5 of them. 1, access. The system must work offline, degrade, and also be able to degrade gracefully on low-end devices, 2G or 3G. 2, usability. The contents in Kiswahili and relevant local languages, low literacy designs are essential for usability. 3, safety. Clear clinical scope, human oversight. 4, protection as well as accountability, which logs, metrics, and user feedback loops made accessible to counties and communities. From the discussion so far, these are already being put in place, so this is really great for the government of Kenya and the leadership.
First and foremost, I want to thank the DHA team led by Engineer Anthony. From where we sit as the Council of Governors, their partnership has not been without hitches, but it is one of the best agencies we work with, because from where I sit, DHA has gotten us from a habit that we had in Kenya, where we used to have a book called Kitabu ya Hospitali. It used to be half a book, and our patients used to carry them along with them everywhere they go. And the biggest killer of patients in Kenya was not the wrong diagnosis. It wasn't lack of medicine. It was inconsistency of health records that made doctors treat patients who are referred with the same treatment they had in the last previous treatments or visits, without realizing that that was not working because there was no record. The birth of DHA from the three laws that were passed, courtesy of Kenya Kwanza, has come to resolve this problem, and our patients are very happy nowadays, walking to hospital, carrying nothing, and they find the records there, even the records of the hospitals they visited before from their previous visits, which are not necessarily the same hospitals. That is a game changer. We are looking forward to a time when a patient in Kajiado will have the need to be seen in Bagathi, and they just walk in, give their ID card, and their records will be there, with their data being correct and also protected, because that is very, very important, not just to us as a country, but also for the patients. So data protection is something that we need a guarantee on, Anthony, because that has been our biggest worry as Council of Governors. I'd also like to, at this particular time, hail you for giving us a promise to give us end-to-end visibility, which includes a dashboard for the CEC in charge of health, also the governor, And I am briefed that that system works on and off. But I'm sure with the effort you put to reach out more counties, this is an issue that will be resolved.
I am particularly delighted to contribute to this dialogue from the perspective of health care digitization. Universal health care remains one of the most important, powerful tools for advancing equity, justice, and inclusion. Yet many Kenyans, especially in the remote and underserved areas, still face barriers to timely, quality, and affordable health care. Digitization offers a unique opportunity to bridge these gaps. It is more than technology. It's a transformational tool for efficiency, for accuracy, for equitable access, for transparency, and for citizen engagement and empowerment. The Ministry of Health has made digitization a core pillar of the ongoing health sector reforms through very key initiatives, including the Taifa Care digital platform, which integrates healthcare records, telemedicine, insurance management, facility data, and to make sure that we provide care, we prevent fraud, and we improve patient safety and experience. We are also doing community health digitization through the Smart Chap app. Community health promoters can now register households, report illness, track maternal and child health, and make referrals, hence boosting our surveillance, our responsiveness, and our accountability to the people of Kenya. On supply chain and resource tracking, we now provide real-time monitoring of medicines, vaccines, and medical equipment, reducing stockouts, wastage, and disparity. And finally, on health financing and inclusion, using our digital IDs and mobile money to enroll vulnerable population into the social health insurance, hence enhancing financial protection and reducing unnecessary cost. We reflect on the next frontier of devolution. Let us reaffirm our collective commitment to equity, justice, and inclusion through technology-enabled health system. The Ministry of Health stands ready to walk this journey together with all our partners, all our counties, and our communities. We will close the gap and we will open the future. With those many remarks, it's now my duty and honor to launch the Digital Health Agency strategic plan.
Thank you.